So my degree is split. It's 5 years long and it's split into 3 stages. The first 2 years is stage 1, which is not here because I wasn't using Notion at that point. Stage 2 is split into years. Hang on, let me correct myself. Stage 1 is its own year, then stage 2, year 2 and year 3, so that's 2 years. It's the next one, and then there's stage 3, years 4 and 5, where you complete the degree, and your level of clinical exposure increases sort of step by step as you go. So stage 1 there was no clinical exposure, it's all lectures. Stage 2, years 2 and 3, you had a bit more, maybe 50% split. You're in the hospital, GP, that sort of maybe in the community as well. And then stage 3 is where I am now, years 4 and 5. I'm in year 4, and that is probably 80-90% in the clinic, in the hospital, out in the community, and then only 10% lectures and things like that. So it's much more fun, but it gives you less time to review material and go over lectures and things like that. So we're going to do some right now, and we're going to choose what to go over. So I'll show you my Notion and how I split all of my note-taking, revision. This is based purely on my current year, and I've got one for the year before, and there's not much in this one because I wasn't really using Notion much at that point. I've got all of my previous exams, my progress tests, that's what that stands for. I don't think I can actually show you that stuff because it's produced by my university and they don't even give us access to that. I only had it because me and my friends, try to remember their questions and write them down. I've got one here recently, that was in November. So my blocks are women's health, child health, that's emergency medicine and critical care, mental health. This is a project we have to do, long-term conditions and acute care. So these ones actually go into year 5, so I need to move those. But I'm currently on child health, that's basically paediatrics and neonatology, a little bit of antenatal stuff as well, and perinatal. So maybe we'll go over some child health, but what could be quite cool is to look into my overall medical school thing, which is when I am going over conditions or drugs, procedures that are not specific to a block. I'll throw them in here, so I have a list of all the areas of medical whatever here, ranging from, as you can see, cardiology and vascular medicine to rheumatology, hematology, genetics, dermatology, endocrinology, which I hate, by the way, it's my least favourite one. This is not really fleshed out, but if we jump into, I know that cardiology will probably have a fair amount in there, so you will have maybe some banner topics and then some specific conditions in them, or maybe it'll be less of a condition and more of a symptom like angina. So you can have stroke, obviously a condition, TIA a condition, a banner topic, valvular heart disease, so there's a whole selection of those, arrhythmias, a whole selection of those. But obviously if I want to search for something specific, it's probably easier for me to just quick find it. Anyway, let's go into child health because I know actually what I want to go back over. So I've got lots of stuff that I need to fill in, but let's go through some cardiology because I was recently doing this, and I think we would be good to go over some of these heart diseases. So the atrial fallow was something that I was in the process of going through, so perhaps we'll actually go through that. There's a whole bunch of congenital heart disease to be aware of: ventricular septal defect (VSD), atrial septal defect (ASD), and then a kind of combination, depending on the severity, what we call the atrioventricular septal defect, a VSD. I've fleshed those out a bit, so I'm quite happy with those at the moment. But let's go through tetralogy of fallow. So this is obviously, as we explained, a congenital condition, and it is four coexisting pathologies, or that's why obviously it's called tetralogy, because it's four things combined that define the disease itself. One being ventricular septal defect, which maybe we'll touch on later. It's essentially a defect between the ventricles of the heart, so the wall between them won't develop properly. There will be a joining of the left and right ventricles, which can lead to all manner of issues. Usually it's just a right to left sided or left to right sided shunting of blood, which can eventually lead to right to left sided shunting. Might be easy just to go into that separately. An overriding aorta, pulmonary valve stenosis, and right ventricular hypertrophy. When considering the effects of these pathologies below, think of them essentially working together to create a perfect storm which enhances the right to left shunting of blood, sort of at the back end of ventricular septal defect. All of this together results in the development of right ventricular hypertrophy. So that's my own little, most of this will be copy and pasted from various resources, and then I'll highlight the important information, put in some diagrams here and there. But in a sense, it's VSD overriding aorta and pulmonary valve stenosis which act together to result in right ventricular hypertrophy and all the other accompanying signs and symptoms, and negative effects of that. So here you've got your heart, and this just explains all the issues we just had. So the overriding aorta, but essentially what an overriding aorta is it's more positioned over the septum, central septum of the heart, I believe. So especially when you have ventricular septal defect, so there should be a thick wall between them, but instead there's almost like a fistula between them. I hope that's the right terminology. The aorta's overriding that septum area. It's more towards the right side of the heart, which means that it creates issues with the pressure of the blood. Now I will reread this as we go, because I think I may be a little bit inaccurate with that, but that's the main understanding, is the position of the aorta. Pulmonary valve stenosis, we might go into that down here, but essentially that's just like the valves themselves, as it kind of suggests. They get thicker, they become kind of stiffer, and they don't move properly. There's a bunch of pathology with that. And then right ventricular hypertrophy, so the right side of the heart muscle becoming much thicker. Again, loads of pathology associated. So ventricular septal defect allows blood to flow between the ventricles. The term overriding aorta refers to the fact that the entrance to the aorta, the aortic valve, that's this bit here, is placed further to the right than normal, above the ventricular septal defect. This means deoxygenated blood enters the aorta from the right side of the heart. Okay, I see. So if you have VSD without an overriding aorta, you might kind of get away with it a little bit because you're still majority getting left-sided blood, which is obviously oxygenated. However, with an overriding aorta, you are now getting more due to the increased pressure from the right side and the position of that aorta entrance. It is greatly favouring deoxygenated right-sided blood going into the aorta, and therefore, obviously, you don't want that going into your systemic system at a greater proportion, at least. Stenosis of the pulmonary valve provides greater resistance against the flow of blood from the right ventricle. This encourages blood to flow through the ventricular septal defect and into the aorta rather than taking the normal route into the pulmonary vessels. Therefore, the overriding aorta and pulmonary stenosis encourage blood to be shunted from the right to the left, causing cyanosis. And this is essentially shunting of the blood. The increased strain on the muscular wall of the right ventricle. So this is what I mean, is this stepwise process as it attempts to pump blood against the resistance of the left ventricle, and the pulmonary stenosis causes right ventricular hypertrophy, thickening the heart muscle. So this eventually will lead to a right to left cardiac shunt. So it would have initially been left to right, and then as you get that hypertrophy, it moves due to the pressure changes. So this means blood bypasses the child's lungs. The blood bypassing lungs does not become oxygenated. Deoxygenated blood enters the systemic circulation, causing cyanosis. The degree to which this happens is related mostly to the severity of the patient's pulmonary stenosis. So that's a really important factor. So investigations that can be done: echocardiograms, Doppler flow resistance increases, or the systemic resistance decreases. So you can imagine how that would shift the pressure towards that side of the system. For example, if the child is physically exerting themselves, they are generating a lot of carbon dioxide. Carbon dioxide is a vasodilator that causes systemic vasodilation and reduces systemic vascular resistance. Blood flow will choose the path of least resistance, so within the chambers of the heart itself, the right ventricle will then favour pushing the blood from that side through the VSD and into that overriding aorta. Blood will be pumped to right ventricle to the aorta rather than the pulmonary vessels, bypassing the lungs, creating these issues. These episodes may be precipitated by waking, physical exertion, or crying. That's obviously an important one in children. The child becomes irritable, cyanotic, short of breath. Severe spells can lead to reduced consciousness, seizures, and potentially death. TED spell treatment options. They should squat. That's going to increase your systemic vascular resistance. You can put the knees to the chest. I mean, raising your legs will do this sort of thing, you know. That's a really good one if someone has a very, very low blood pressure out in the world. That's an example for you guys. Squatting. Okay, there you go. Squatting increases systemic vascular resistance. This encourages blood to enter the pulmonary vessels. So medical management. Supplementary oxygen, of course. Beta blockers, they relax the right ventricle and improve flow to the pulmonary vessels. So again, just changing that the system of pressure and where the blood is going. IV fluids increases preload, increasing the volume of blood flow to the pulmonary vessels. Morphine decreases respiratory drive, resulting in more effective breathing. Sodium bicarb buffers any metabolic acidosis that occurs. And phenylephrine infusion can increase systemic vascular resistance. Management and prognosis in neonates, so newborns, prostaglandin infusion can be used to maintain the ductus arteriosus, so that would kind of reverse the system in a way, which is kind of interesting, allowing blood to flow from the aorta back to the pulmonary arteries. That's really interesting. Generally, a patent ductus arteriosus is a condition in itself, but in this sense, it kind of, they act against each other. Total surgical repair by open heart surgery is definitive. Mortality is 5%, those but really high. Prognosis depends on the severity, however, it is poor without treatment. With corrective surgery, 90% of patients will live into adulthood. Wow, so it's a big topic. There's a lot of things that we would like to cover in the background, like some more specific stuff related to ventricular septal defect itself. Maybe go over stenoses, things like that. But overall, that's pretty useful. I would recommend checking out some of the if you want to learn more, some of the resources that I use. So Zero to Finals is pretty good for a breakdown specifically for medical students. I also like their podcast, it's pretty good. As you can see, that's my kind of main thing. Almostadoctor.com is very good, and Amboss will have a really highly detailed but USA management and protocol specific explanation of these things. Those are my three go-to resources. So yeah, guys, thank you for watching. Hope you enjoy it. Let me know in the comment section if you have a area of interest for me to research or look into next. I can't promise I will go with that suggestion, as I need to learn what is relevant to my placement at the moment, which is in Paediatrics. So maybe keep that in mind. But either way, send me your interests, and I will take a look into it potentially. Hope you enjoyed. I'll see you you again very shortly.